This is Dr. Eric Parsons. I am a family physician at Health Point in Kent, Washington. I have done community health center primary care for my entire career, and I also mentor and teach medical students at our site. I am the Regional Director of Medical Education and Associate Clinical Professor at A.T. Still University, School of Osteopathic Medicine, Arizona, at the Health Point campus in Renton, Washington. I am also an adjunct clinical faculty for the University of Washington School of Medicine in Seattle. The GE National Medical Foundation Primary Care Leadership Program has provided community health centers like ours an opportunity to work in a win-win fashion with PCLP scholars from all over the country. We win by gaining the enthusiasm and time of young learners willing to jump in and kickstart projects to help us assess our tools and systems. The scholars benefit from an early introduction into the world of community health centers, the front lines of primary care for our most diverse and needy populations. A community health center like ours is serving tens of thousands of patients at 10 different sites. We have learned to evolve ways to set up systems to track patient populations and chronic disease groups in order to understand the value that our individual efforts and group efforts bring to our community of patients as a whole. This helps each provider go beyond delivering excellent service to one patient at a time. However, we don't always take the time to assess how well we use these tools, such as the electronic health record, the patient portal, telemedicine, and group visits. This summer, our community health center colleagues here and across the country hosted some terrifically talented PCLP scholars who have started the ball rolling for us. As you can see from these presentations, we will begin to have the data and feedback needed to support the systems that work and improve or eliminate those that are not effective. Thank you to the GE, NMF, PCLP scholars, staff, and volunteers.
Hello, my name is Adena Hicks, and I am a second-year medical student at Michigan State University College of Human Medicine. I am a GE National Medical Fellowship Primary Care Leadership Program scholar, and my placement was in Orlando, Florida with the Healthcare Center for the Homeless. The title of my project was The Reality of Expectation, Provider Productivity. The objective of my project was to determine the perception of productivity standards on providers at the clinic I was placed at, which was called Orange Blossom Family Health Center, as a model for gaining perspective on the challenges in modern healthcare. The way that I went about this, or my methodology, was to use a descriptive cross-sectional study utilizing surveys, which I designed to include Likert scale and open-ended questions. Comparative analysis was used to determine the patterns and responses between administrators and providers. The key findings that I found in my project was that administrators generally felt that patient quotas were reasonable and manageable. However, providers generally felt that patient quotas were unrealistic and even negatively impacted patient care. The recommendations that I made for this project were two broad recommendations and two specific recommendations of creating an environment in which the needs and concerns are both welcomed and valued. Also, to be willing to collectively create a solution that incorporates the unique aspect of the staff and facility at Orange Blossom Family Health. And the two specific recommendations I made were to perform regular needs assessments to determine where staff has concerns about productivity, and to conduct workflow assessments to determine areas for improved efficiency. Thank you very much.
Hello, my name is Travis Howlette. I'm a second year at Albert Einstein College of Medicine, and this past summer, 2014, I was a primary care leadership program scholar at Rochester, New York. And the program that I will be discussing that I had conducted with the Anthony L. Jordan Health Center and Dr. Jennifer Carroll's team was the Healthy Weight and Wellness Program. So the Healthy Weight and Wellness Program is the name of a new clinical program at Anthony L. Jordan Health Center to help patients eat healthier, improve their fitness, lose weight, and improve their energy and well-being overall. The targets of this program are patients that are overweight or obese that have 1 to 2 weight-related chronic conditions or symptoms. Some of these would include diabetes, hypertension, and chronic kidney disease, among the few, within Rochester, New York, and Monroe County. The innovative components of this program involves a structure of a group medical visit, which serves as a method to develop a supportive environment, and a financially sustainable program that utilizes regular medical visit reimbursement to support the program. The Healthy Weight and Wellness program was piloted for 12 weeks for a total of 6 group medical visits. One visit consisted of each patient checking in, having their vitals and history taken, and then participating in the group-based interactive programming. Any additional time in the program was set aside for patients to have one-on-one counseling with their physician or nurse practitioner. The sample programming curricular included education on the USDA MyPlate, sampling raw fruits and vegetables, and exercise and instruction videos on physical activity. For a little background, according to the 2012 Monroe County Adult Health Survey, 36% of adults in Rochester are overweight, and additionally 30% of adults are obese. This is higher than the average obesity rate for New York State, which was 24% in 2012. Factors like location in the city, urban versus suburban, and race have been shown to exhibit great disparity within Rochester's obesity rates. In fact, according to the 2012-2013 Gallup Health Weighs Well-Being Index Survey, it was concluded that Rochester is number 6 out of the top 10 most obese major U.S. communities. The implementation of the Healthy Weight and Wellness program started with a goal of enrolling 20 patients per group medical visit session. The ultimate goal is to reach 40 patients within 2 groups. The criterion that was used to enroll patients into the program was patients must be overweight or obese with a greater than or equal to 25 BMI, aged 18 years or older, have at least 1 to 2 weight-related chronic conditions or symptoms, English speaking, not necessarily English as a native language, ambulatory, and current patients of the Anthony L. Jordan Health Center with some form of health insurance, either public or private. One enrollment strategy for the Healthy Weight and Wellness program began with the enrollment coordinator asking clinicians within the Anthony L. Jordan Health Center network to refer patients they felt were eligible according to the criteria. Clinicians would identify a candidate for the program, and then one member of the program development team would call the patient to administer the screener and the pre-survey. Eventually, another strategy was used where the Healthy Weight and Enrollment program coordinator would be on site with the clinician's respective clinics. In summary, clinicians would identify a patient that met the criteria for the Healthy Weight and Wellness program, discuss a quick overview of the program, and then call in the Healthy Weight and Wellness program enrollment coordinator to enter the room to discuss the details of the program and administer the screener and pre-survey. According to our results taken from our pre-screener surveys, the average BMI for the participants who were screened with an N equals to 11 was 41, with 55% ranging between 30 to 40 and 45% that were greater than 40. Max was 56. The most common weight-related chronic condition was hypertension at 91%, depression at 55%, and joint pain at 45%. This was mirrored by the fact that 64% of participants have no physical activity outside of daily walking without the intent to exercise. 73% that claim their quality of life is fair or below, and 27% of participants that claimed that pain was a major barrier to being in the Healthy Weight and Wellness program. As for dietary habits, the average meals, vegetables, fruit, and fast food per day was roughly 2 meals or servings per day, and vegetables were about 1.5 servings per day. Finally, 30% of participants claimed that they got less than 4 hours of sleep per night. And based on shared stories from the first visit, it appears that the reasoning may have been associated with poor habits leading up to their trying to fall asleep. As part of my goal for this program, I was looking to look for ways to see the process and give some recommendations for how we can improve programs like this for other sites and centers, kind of like a lessons learned. And in our last meeting with the program development team, we discussed these few topics, and I added a few as well for future consideration. But we broke it down into enrollment and program planning and implementation. So for enrollment, we suggested that we use the variables in the screener to capture patient-driven topic areas for the curriculum. Variables like barriers, their weight-related chronic conditions, and reporting of their quality of life were mirrored very well within the discussion of the desirable topics for the program within the first group medical visit. Also, another recommendation was to start enrollment and screening / surveys earlier. By capturing screener data before the development of the curriculum, we would reduce the amount of additions and changes we ultimately would make based on that first clinical visit recommendations from the patients. Also, have a member of the program development team be present at the clinics being used for recruitment. By meeting with the clinicians in person, it sparks more motivation to actively refer patients to the program. It also provides an on-site resource for the clinicians to utilize to give more information and answer questions directly about the program. The benefit to the program development team of this arrangement is it allows for a one-stop shop of enrolling and screening / surveying patients. Another recommendation, while conducting the screener and surveys, discuss as a team how to ask and explain each question. With multiple people providing these screeners and surveys, it is important to make sure that if questions are being explained, it is done with some degree of consistency, or not explained at all, and patients determine what the meaning might be of the questioning. So, for program planning and implementation recommendations, the first recommendation was to develop a quick template within the electronic health records system. One of the biggest factors in a healthy weight and wellness program is the balance of time. Since the program is considered a group medical visit, each patient must undergo quick assessments, which includes vitals, discussions with the care provider, etc., and still have time to be part of the program. By having a quick template with limited free text entry, it will free up more time for the curriculum. Make sure, also another recommendation, make sure to load the template for each patient prior to the visit. By placing the patients in the EHR schedule for the group medical visit, it will save time by adding the developed template. The more preparations before the visit, the better in regards to managing the time balance. Once again, that's the medical visit versus curriculum programming time balance. Another recommendation is call patients during the off week to check in, and the day before to remind them of the visit. Another recommendation was to look out for literacy issues. One great method to determine if there might be an issue with literacy in person is to watch how the patient fills out the pre-survey. If enrolling over the phone, ask whether the patients have any reading difficulties. Another recommendation is prepare the program development team to be sensitive to group dynamics. Since the program relies on group visits with patients who are typically strangers to one another, it is wise to monitor and assess the group dynamics. Continue to look for solutions to tempering strong personalities, reducing long testimonies, and preventing peer-to-peer negative statements. Another recommendation is provide handouts that will capture chief complaints, goals, review of systems, and current medication lists. Patients can help reduce the amount of time for the clinical assessments by filling out handouts before they are pulled into the side room for their individual visit. And the final recommendation that we concluded was to create a shared digital filing system for handouts. So, in conclusion, medicine is undergoing a lot of changes to coincide with the Affordable Care Act's emphasis on preventative care. After collecting data from the screeners and pre-survey and implementing the first visit of the Healthy Weight and Wellness program, there is a lot of excitement around this program as an attempt to deal with Rochester's obesity issue. This is just one example of a local health center trying to meet the needs of the community. From the first group medical visit, there was a lot of positive feedback given from the patients about the program and their excitement. Measures of retainment in the program will be needed going forward to determine how effective the program is at engaging the patients. And at this time, I want to just quickly do a quick thanks to and acknowledgments of the GE Foundation, the National Medical Fellowships, and the staff that put this all together. And I also want to thank the sites that I worked with, which was the Anthony L. Jordan Health Center, as well as the Rochester Primary Group Network, and as well as Dr. Jennifer Carroll and James Sutton for their mentorship and guidance throughout this process. So thanks again for this great opportunity.
I'm Heather Luther, a family nurse practitioner student at the University of Hawaii, Manoa, and my project focused on barriers to primary care. I've been interested in community health for many years and have studied it both during my Master of Public Health and Master of Science in Nursing curricula. One of the topics that I have encountered on numerous occasions is how many people aren't able to receive the health care they need, starting with primary care, because of barriers they face to doing so. These barriers can include a lack of insurance or money for the care, inadequate transportation, long working hours with no time off, language barriers, and so on. I wanted to use this experience of working in a community health setting at United Neighborhood Health Services in Nashville, Tennessee, to explore in more detail exactly what community health patients see as barriers to healthcare and how the community health center might be able to help patients overcome these perceived and real barriers. The methodology for this project was an anonymous survey that collected patient demographic data and responses to health questions regarding their biggest health concerns, biggest barriers to getting needed health care, and the desired improvements to the clinic. Over 30 patients completed these surveys during a free health screening event held at the clinic. The process of collecting this information and the information itself revealed several key findings. First, patients reported predictable health concerns and barriers to health. These included concerns about weight control and diabetes, and barriers such as inadequate insurance, money, transportation, and clinic hours. In addition to these findings that confirmed my initial hypothesis, the process of taking the survey itself also indicated some more interesting findings that showed how systemic weaknesses in the healthcare system create substantial barriers to primary care. Notable among these findings are the fact that underserved patients are generally hesitant to provide information to healthcare providers and are underinformed about the resources available at community health clinics. However, it is also the case that the incentives faced by many of these disadvantaged individuals make it rational for them to avoid seeking health care for all situations, except those requiring immediate attention. Even though the community health clinics offer accessible and free or affordable care, the costs and time associated with prescription drugs and specialist care are significant burdens for many patients with no easy solution. A referral to a specialist can take months, if not longer. Based on these findings, I recommend that the clinic develop new or improve existing clinical programs to address the concerns that patients identified. These could include free classes on weight control and cooking for diabetes prevention, longer clinic hours, and better transportation options to the clinic. The clinic should also seek to develop partnerships across the healthcare system so that it can better function as a gateway to services beyond primary care that patients may need, so that they have an assurance when they seek primary care, the next step will be accessible to them in a timely and efficient manner.
The effect of hygiene on dermatological concerns in homeless patients. The purpose of my project was to better understand the dermatological concerns that homeless patients present to the clinic with in Nashville, Tennessee, in order to make a recommendation to community health centers as to a way to better improve skin-related health outcomes for this patient population. My objectives were to determine whether personal hygiene plays a significant role in the skin-related conditions of homeless patients, and to provide a model for sustainable hygienic intervention for and in this patient population. My methods included using the electronic medical records to determine the percentage of patients that presented with skin-related concerns as their chief complaint, and then to determine whether these concerns could be prevented or alleviated by hygienic modification. I also created the SO initiative, which stands for Soap on Wheels, a soap and sanitizer drive conducted in conjunction with a hygiene workshop at the local homeless shelter. Of the 102 patient records analyzed, almost 20% presented with a dermatological concern as their chief complaint. 7 of 11 of these complaints can potentially be prevented or alleviated by a patient's personal hygiene regimen. My recommendations to community health centers is to continue the SOW initiative, focusing on educating the patients about the correlation between their hygiene and their skin's health, and empowering the patients with the tools they need to be compliant and successful in their endeavors to improve their personal hygiene. Thank you for listening.
Electronic health record use, healthcare providers' perception at a community health center by Gina Robinson, Arizona College of Osteopathic Medicine at Midwestern University. Site location in San Antonio, Texas. The objective of the study was to determine healthcare providers' perceptions on new opportunities electronic health records created in patient care. We identified physicians, physician assistants, and nurse practitioners from acute care, family medicine, obstetrics and gynecology, and pediatric specialties at 21 medical clinics for a 2-page paper questionnaire. Healthcare providers agreed that electronic health records coordinated care between medical staff and departments, allowed up-to-date patient health information to be received, made electronic prescribing fast and easy, and reduced medical errors. However, providers disagreed that electronic health records increase productivity. Overall, healthcare providers are satisfied with electronic health records. From the study, here are the following recommendations. Create a handbook that outlines the intended use of the electronic health record system and documentation expectations for healthcare providers. Provide electronic health records training and 24/7 technical support, and administer an annual questionnaire.
Hello, my name is Pollyanna Sanchez-Martinez. I am a second-year medical student at Georgetown University and 2014 Primary Care Leadership Program Scholar. This summer, I had the opportunity to do my independent service learning project at Orange Blossom Family Health in Orlando, Florida. My independent service learning project was on improving the rate of pap smear screenings amongst low-income and ethnic minority female patients at Orange Blossom Family Health. I wanted to do this because I have a personal interest in women's health and preventative medicine. Also, despite offering free pap smears, Orange Blossom Family Health has been in the 25th percentile for 2013 and 2014 as reported to the Health Plan Effectiveness Data and Information Set benchmark. This is based off of patient compliance and non-compliance, or the rate of patients being offered pap smears and having them within the past 3 years. This is also significant because HPV-related cervical cancer deaths is also disproportionately affecting women of low socioeconomic status and ethnic minority backgrounds. Consequently, my independent service learning project looks to examine and understand the intrinsic psychosocial barriers and motivators that influence the decisions of low-income and ethnic minority female patients from ages 21 to 65 in pursuing cervical cancer screenings, and what factors influence provider decisions to recommend or perform pap smears on a day-to-day basis. In doing so, finding reasons why Orange Blossom Family Health is below the national HEDIS score are also postulated to be found. So how was this done? A descriptive qualitative cross-sectional study was conducted via 2 surveys, a patient survey and a provider survey. 6 providers were screened, which included family medicine physicians, physician assistants, and nurse practitioners, whereas 100 patients were surveyed while in the medical clinic waiting room. Patient data was then analyzed using a SPSS software to find chi-squared values and correlations between the data. Key findings and significant correlations based off of the SPSS software included patients who were more likely to be compliant were patients who were reminded about an upcoming pap smear, patients who said that their providers communicated their pap smear results with them often, and patients who said that they always understood their pap smear results. Also, female providers were more likely to remind their patients of an upcoming pap smear. Consequently, recommendations to the facility included provider training on the new guidelines before the pap smear, as well as to remind their patients at least 1 week before the patient's appointment of an upcoming pap smear. More recommendations and key findings can be found on my executive slide as well as my full PowerPoint. Thank you so much for your time. I hope you have a wonderful day.
Hi everyone, my name is Kenji Taylor. I'm a fourth-year medical student at the University of Pennsylvania. This past summer, I participated in the primary care leadership program at the East Arkansas Family Health Center in West Memphis, Arkansas, the rural part of Northeast Arkansas. The title of my project was the implementation of an online qualitative and quantitative employee satisfaction survey across the East Arkansas Family Health Center system, or EAFHC. The objective of the project was to implement a scalable and repeatable online tool to assess employee satisfaction and build off of the same employee satisfaction that I did last year as a PCLP scholar. So what we did was create an online survey using a Likert scale from 1 to 10 and free text questions. We then gathered emails from employees across the 5 different sites in Northeast Arkansas, deployed the survey, went around to each of those 5 sites to make sure everyone understood how to complete the survey, and then collected all the results. So what I found from the survey was that the loyalty to EAFHC and appreciation of the value of their community service was clearly conveyed as a main strength of the organization. Some of the areas of improvement include leadership at the supervisor level, communication throughout the organization, training, and finally professional development. Based on the results of this survey, I recommended continuing to survey employees annually and trend results over time, have a biannual committee meeting with reps from all sites to improve communication, and finally conduct a needs assessment of the specific employee training needs headed by a committee. So that concludes and summarizes my project. Thank you very much.
Hello, my name is Christina Vu. I am a rising second-year medical student at Arizona College of Osteopathic Medicine at Midwestern University. My placement for the summer was Watts Health Corporation in Los Angeles, California. The title of my project is Increasing Immunochemical-Based Fecal Occult Blood Test Completion in a Federally Qualified Health Center. The objective is to test the effectiveness of telephone reminder system in patient education, instructional flyer on FOBT kit return rate, along with recommendations for workflow improvement and sustainability at Watts Healthcare Corporation. The methods include using the Plan, Do, Study, Act cycles to test for improvements. In PDSA Cycle 1, 80 randomized patients were called with a reminder 7 to 10 days after receiving immunochemical-based FOBT kits. These were compared to those without reminder calls. PDSA Cycle 2 included the addition of an educational flyer on the importance of colorectal cancer screening with clear directions on where and when to bring the FOBT kit. This was tested as a response to PDSA Cycle 1 results. Lastly, the workflow was analyzed by shadowing the Adult Medicine Department at Watts Health Center, and recommendations for improvements were made based on a literature review. Key findings were telephone reminder calls increased FOBT return rate by 15%. Educational instructional flyers proved useful by the patient care team in the delivery of the FOBT kits. In the workflow analysis in the Adult Medicine Unit at Watts Health Center, few weaknesses were noted. Patients did not understand the importance of annual FOBT-based screenings. Patients did not understand what the test was for. There is no uniform timeline to tell patients where and when to bring the testing kits back. There were no Spanish instructions for the FOBT kits given to patients. Recommendations included telephone reminder calls and educational flyers should be incorporated into the FOBT workflow as supplemental tools. However, future improvements should be more focused on increasing patient activation for greater impact. Based on literature, education videos on colorectal cancer should be screened in waiting rooms as part of patient engagement. Also, providers are recommended to make the recommendation provide education and physically give patients the IFOBT test. Lastly, in order to uphold the patient-centered medical home model, PDSA cycles should be constantly ran until high-quality care goals are reached. Active leadership is required for implementation. Thank you.